Hello and welcome to another episode of the ABIP podcast. This is Abhinav Agrawal, your host from the Zucker School of Medicine at Hofstra Northwell in New York. The views expressed in this podcast are those of the speaker alone and not necessarily those endorsed by the AABIP. Today, we have the pleasure of hosting Dr. David Feller-Kopman for this very interesting but challenging topic discussing the IP perspective and the pulmonary perspective in the management of recurrent respiratory papillomatosis. Dr. Feller-Kopman is a well-renowned personality in the field of IP and is currently the Chief of Pulmonary and Critical Care at the Dartmouth-Hitchcock Medical Center and a Professor of Medicine at the Geisel School of Medicine. Welcome, David, and thank you for joining us today for this podcast.
Thanks, Abhi. Pleasure to be here.
Absolutely. So let's dive into the topic. So with regards to RRP, we know that distal airway involvement can occur in 2 to 5% patients with papillomas of the larynx, and with about 1% patients having involvement of the pulmonary parenchyma. And I've seen that our ENT colleagues frequently deploy the use of microdebrider in the management of glottic or laryngeal disease. So let's say we have a patient, a 28-year-old with mid-tracheal involvement with RRP causing symptoms. What is the approach to these patients in terms of endoscopic therapy?
Yeah, so that's a great question with very little data to support opinion. There are very few randomized trials, certainly no comparative efficacy trials that I know of. So I think your approach is really dependent on your training and your own experience. I personally love the microdebrider in lesions that affect the trachea, either high or low trachea or proximal mainstem bronchi. The benefits of the microdebrider, I think it causes less aerosolization than a laser, and we'll talk about that in a second. It's fairly good in controlling hemostasis given the suction that you could attach to the microdebrider. But there's very little data for it. As you know, there are lots of modalities that have been used to treat tracheobronchial papillomatosis, including a host of different lasers. The ENT literature has been using a lot of the KTP laser just because its efficacy in the vascular bed of the papilloma. So I've used KTP laser, I've used YAG laser, I've used diode laser and holmium laser. So one of the theoretical disadvantages of any thermal modality is that there have been viral particles isolated in the plume. So with ventilation, could some of these viral particles progress more distal into the parenchyma or more distal airways? It's certainly possible. I'm not aware of any case reports of patient-to-physician transmission. That being said, the current recommendations are that, you do wear N95s and a face shield and appropriate PPE. So I do like the microdebrider based on that theoretical risk. Now, as you also know, papillomatosis is a progressive disease. So all of these patients will progress, and they progress into the more distal airways in the parenchyma. So it's really hard to even study an effective treatment in terms of disease progression because these patients do progress. So if you use a microdebrider on 10 patients and they progress, would they have progressed if you used a laser? And they would have. The question is the speed at which they progress, I guess.
Right. No, and as you mentioned, it comes down to a lot of training. So where I trained, just from personal experience, I did not have microdebriders. So we would, and to your point, thermal therapy, the risk is of at least a theoretical risk of aerosolization, both for the patient at the distal airways and then, for the provider and the team that's present, even in the presence of PPE. So what about cryotherapy? Have you ever used or, thought about using cryotherapy for debulking or even treating the base? Let's say if you use one therapy for debulking and then cryotherapy for the base?
Sure. And likewise, cryo is a great modality. One of the beautiful things about a cryotherapy probe is that the normal airway is generally resistant to cryo injury, so it's harder to hurt someone. compared to a laser where you could shoot through the airway. There's not a lot of data for cryotherapy. I probably would avoid cryospray for the same reasons that I would steer away from the laser personally, with the additional fact that there are some data for laser, but I'm not aware of any data for cryospray.
In addition, do you use local therapy, like local antiviral therapy with either cidofovir or even systemic therapy in these patients when you're seeing them up front or even seeing them for their first recurrence or you're following them?
Another great question. So first off, I do make sure that everybody has received the HPV vaccine. There are some data in the pediatric literature that it reduces the incidence of progression, but even as a treatment modality, HPV vaccine might increase the interprocedural interval. And then in terms of cidofovir, I think the current recommendations are that if you're requiring more than 4 to 6 procedures per year, you should consider local and or systemic therapy. At Hopkins, we had a otolaryngology colleague, Simon Best, who has done some amazing research in using bevacizumab. So I have a fair experience with bevacizumab, and I got to tell you, in the 20 years that I've been treating papillomatosis, I've never seen anything melt away the disease like bevacizumab. I've had patients with severe tracheobronchial disease, and within 1 or 2 doses, their airways are almost clean. It is some of the most amazing things that I've seen. And I've also seen complications from the bevacizumab too, including horrendous tracheal esophageal fistula. So it's not without risk, but it does seem to work. Now, whether you could inject it locally or do you need it systemically, that's where we're awaiting data. But I would reference people to Simon Best.
Absolutely. No, and I know there are some NIH trials and something that we were considering ourselves recently for one of our patients, bevacizumab, and thank you for letting us know that. So do you, in addition, you mentioned about systemic therapy with bevacizumab. So one of the questions that I faced recently myself was that we know that there is a rate of malignant transformation in these patients, up to 3 to 7% in adults. And let's say we have a patient with a history of laryngeal papillomatosis. The laryngeal aspect is under good control, gets frequent follow with ENT, but now has a pulmonary lesion that is enlarging. It, radiographically looks like a papilloma that seems to be enlarging. Would you, just from the diagnostic perspective, would you do a biopsy to assess for transformation? And what prompts your decision to do a biopsy in these patients?
Yeah, I think that's another great question. And I think we certainly do need to worry about malignant transformation. Papillomatosis could look like a lot of things on imaging. It could look like nodules. It could look like cysts with either thin or slightly thicker walls. It could look like a cavitary lesion or even a pulmonary mass. So I do think you need to keep a broad differential. And I do think you need to keep squamous cell transformation on your short list of what this could be. Because if it's an early localized squamous cell, it could be cured with resection. And this is sometimes where a multidisciplinary, either thoracic tumor board or a complex airway conference with your ENT colleagues and people who just see a lot of this, because it's a fairly rare disease. So you always want lots of eyes on this, get your thoracic radiologists involved. But I do have a low threshold to biopsy to make sure that there has not been malignant transformation. So,
when we biopsy them, so I had this interesting case recently where once you biopsy them, either you're going to see squamous transformation, but I had this patient, one of them, who had a high-grade dysplasia. And that prompted we took it to a multidisciplinary tumor board. But let's say you have this patient we talked about and now who has high-grade dysplasia. What are the steps that you would pursue? Would you then straight refer the patient for a surgical resection if this is the only lesion? Or would you consider systemic therapy or even follow up to see if this is getting larger? What prompts the decision, again, one way or the other, in terms of systemic therapy versus resection, apart from surgical candidacy?
Yeah, so that's another really good question for which there's not a lot of data. I think we all have to realize that reading small biopsy specimens is an art. And we're learning that even with non-small cell lung cancer, if you show tBNA specimens to a bunch of cytopathologists, you sometimes get variations in the read. And then especially with dysplasia, metaplasia, carcinoma in situ, things like that, there's a lot of inter and intra-observer variability. So you need to first trust your pathologist. The decision about resection is really going to be dependent on where the lesion is. You sort of hate to do a lobectomy for high-grade dysplasia. If it's a peripheral nodule that could be taken out with a wedge, that's a different thing. It depends how what your access to minimally invasive thoracic surgeons is like. And the status of your patient. As you know, a lot of these patients are young. This is the part of interventional pulmonary that I find fascinating. We're all pretty good at palliating malignant central airway obstruction in a 85-year-old with metastatic cancer, but the bigger and more challenging question for us is how do we keep someone who's 35, 40 years old with quote unquote benign disease, and I don't like calling this benign disease, I'd rather call it non-malignant disease. How do you get someone who's 35, 40 years old to 75, 80 years old? That's the challenging and intellectually stimulating part of all this.
Let me make it even more challenging. So let's say we have now 2 or 3 nodules which are enlarging in size. And it has happened where we have these young patients who have the laryngeal disease under control and now have 2 or 3 nodules that are slowly increasing in size, where even if you biopsy them and we see transformation, surgery is may not be the best step because we cannot go around doing lobectomies or even, especially if they're not accessible to a wedge. So what do you pursue? You talked about bevacizumab, like systemic therapy in these patients, especially if they have worsening pulmonary nodules or increasing in size?
Yeah, so this is where I think we're going to need to work in collaboration with our medical oncology colleagues as well. Even for the bevacizumab, we work with them because that's not a drug that I prescribe. Even if we're just treating central airways, we're going to be working with them. But certainly in patients who you're worried about malignant transformation, I would want to get their input on, do you treat this sort of as papilloma? Do you treat it as squamous cell? So that's something that's out of my ballyhoo, if you will.
Absolutely. I think the importance of multidisciplinary thoracic tumor board or the complex area and people with experience comes into play when dealing with these challenging cases. So coming back to our first patient, so let's say you treated the patient with either a microdebrider or someone treated the patient with, let's say, snare plus treating the cryotherapy, using cryotherapy for the base. How often do you perform surveillance? How often do you look for recurrence? Do you base it upon symptoms, or do you perform frequent bronchoscopic or just imaging surveillance? How do you manage these patients over the long run?
Yeah, so again, very limited data. My personal preference is to take a look down sort of as little as needed, but as much as needed. I don't want to necessarily wait until patients are symptomatic because, as you know, you could lose a significant amount of airway real estate without developing symptoms. But there are some people who progress more rapidly than others. So if it's a person that I'm seeing for the first time and I treat them, I'll usually take a look down maybe 3 to 4 months later just to see what's going on, and then base the subsequent bronchoscopies on what I'm seeing. You don't want to necessarily intervene too much, not only from an inconvenience standpoint for the patient, but again, I don't want to do things that are going to make things worse. So I try to be somewhat conservative, but not so conservative that I'm, waiting for symptoms.
And that's a fine line. Of course, we don't want to make things worse, both in terms of symptoms-wise and not do unnecessary intervention, especially with the risk of, especially if you're using thermal therapy, aerosolization. Do you always treat them? Let's say there's mild recurrence when you go in. Do you always treat the base to see if they have a sustained effect, or if you see a obviously large lesion, that's when you treat them, like especially even with the microdebrider or something?
No, I think if I'm putting a patient through the risks of the procedure, I generally try to treat what is visible. And I do a thorough airway exam each time. So just because someone has a big lesion in the mid-trachea, you do have to look down to the sub-segmental level and make sure nothing's more distal.
Absolutely. I mean, there's a recent patient that I had that had tracheal disease that we were intervening on, and then we located another couple of papillomas in the right lower lobe. So absolutely, you have to stress on the importance of doing a thorough surveillance exam each time you go down, especially if you're subjecting these patients to a procedure, one that they need, but making sure that we cover all the airways. Are there any other clinical trials that you're aware of? I know NIH has a couple, but that you refer these patients out to, or is the systemic therapy with Avastin or bevacizumab your usual go-to?
Those are what I'm aware of, and I know Simon Best has some, and I believe those are in connection with the NIH. I do believe there's also a trial looking at anti-PD-L1 drug, avelumab, and that's also through the NIH.
Absolutely, yeah. So that's I came up with that when we were discussing our patient.
And I think there's also one on Pembro as well.
Yep. So I mean, all of us are waiting with bated breath for the results of those, so we can have more options for our patients, especially with those with significant either parenchymal or rapid recurrence. Do you have any other comments? This has been great. It's been very helpful both for me personally, and I'm sure this will be great for our listeners to get guidance on this very challenging but interesting topic in IP.
Yeah, no, I would say just given the rarity of the disease, it would be great to have all of these patients in sort of a central prospective database where we could really figure out the best treatment and ideally start comparing treatments. So whether that's through ABIP or SAB or the NIH, we should have sort of a papillomatosis registry where we could look at this stuff prospectively.
I think that's a fascinating idea, especially with ABIP right here. I think something that we could bring up and start a multi-center registry, both prospectively, to follow these patients, both for interventions and systemic therapy, and put our collective brains and experience together. Thank you so much again for the opportunity and coming over. This brings us to an end of another episode of the ABIP podcast. Please don't forget to subscribe to our YouTube channel for the latest updates and discussions with the experts in the field of IP.